I'm John Cook, Chair of the Department of Cardiovascular Sciences here at Houston Methodist Hospital, and I'm here with my colleague, Alan Lumsden, who's the Chair of the Department of Cardiovascular Surgery. And our guest today is Dr. Will HIATT, who's a Professor of Cardiovascular Research at University of Colorado and President of CPC, Colorado Prevention Center, which is a center that runs most of the PAD trials, peripheral arterial disease trials in the country and globally. Dr. HIATT just gave a wonderful grand rounds on clinical trials in peripheral arterial disease. And Will, I'd like to start by asking you about the CPC, this corporate research organization that's really affiliated with the University of Colorado. Tell us a little bit about how that works in running clinical trials.
Thanks, John. So we've developed an academic research organization at the University of Colorado. It's modeled after the DCRI at Duke, which is Duke Clinical Research, or the TIMI group, which was started by Eugene Bromwell at the Brigham and Women's Hospital. And there's a group up at McMaster, one starting in Stanford. These are groups of physicians who are based out of major universities who design, oversee, and publish large clinical trials. And so our mission is very much like theirs, which is to bring therapeutics to humans and to improve health. We're the final translational stage. So once a molecule's gone from discovery through early phase human studies, and now you've got to go into the larger trials to demonstrate efficacy and safety that the FDA will approve, that's where we come in. And we work with sponsors who pay for the trials, but the deal is that they have to give us access to the data. We have to have independence on the design, oversight, and decision-making around the trials. And that's an organization I run at the University of Colorado.
The other thing that you've done related to clinical trials is you've served on the FDA, the Cardiorenal Advisory Panel, for 5 years as chair of that, and now you're working with the Endocrine and Metabolic Advisory Panel. Tell us a little bit about your experience with the FDA and clinical trials.
Well, the FDA is amazing. If you think about opportunities in your career to learn things, I find the FDA to be a wonderful training ground. And I have several faculty in my center. I've got one on the Endocrine and Metabolism panel for training. I've got another one on cardiorenal, and another one just recently on cardiorenal. And the reason is that you really see the end result of this huge investment, and you see what the trials teach us, and you see where the flaws are. No trial's perfect. And so you're trying to always assess risk and benefit. And at FDA, you learn about biostatistics, how to interpret big data sets, and ultimately how to opine on whether drugs should be brought forward or not. And that opportunity has been huge. Recently in the field of diabetes, for many years it was bringing drugs forward that lowered blood sugar, and now we have drugs that actually prevent cardiovascular events, SGLT2 inhibitors, GLP-1 agonists. And being part of those reviews and understanding how we got there and why we got there, there's a regulatory science component to this that people don't quite appreciate. So I find the FDA to be rigorous. I think they're good people. I think they're trying to do a good job, and as an academic, you learn a tremendous amount.
Thank you. Is it blood sugar, or is it something else that is responsible for the benefit of these agents?
It's incredible, isn't it? I mean, endocrinologists for years have been lowering blood sugar. And the only benefit from that, quite frankly, is microvascular complications. So renal disease, eye disease, nerve disease. The cardiac benefits of a lower A1C have been elusive. Even if you treat it with lifestyle. So the Look Ahead trial looked at a lifestyle intensive intervention, lowered A1C, no demonstrable benefit on cardiac risk. But the new drugs, which are working through different pathways, are lowering A1C and reducing risk. It's all about the pharmacology, I think. It's not so much A1C, it's not so much glycemic control. There's something about SGLT2 inhibition that particularly seems to associate reduced risk of cardiovascular mortality. And that risk is not quite understood, how that works so effectively. GLP-1 agonists appear to be a balanced effect on both MI, stroke, and vascular death. They look a lot like other cardiovascular drugs. So now the decision in my mind is, how do you lower the A1C? Well, why not use a drug that reduces cardiac risk and not just reduces A1C? That's all new stuff. And that came through the FDA because of a guidance in 2008 that was stimulated by older drugs that might have actually made cardiac risk worse. That's the journey with the FDA. It's an amazing ride. And now there's new therapeutics that I think are groundbreaking.
Just following along those lines, blood pressure is something that we have targeted in the past, but it seems as though some of our best antihypertensive agents have other effects not related to blood pressure that are responsible for their cardiovascular benefit. What do you think about that?
The Cardiorenal Division a couple of years ago reviewed all blood pressure meds. And the question was it the drug or was it the blood pressure? In this situation, it's really all about the blood pressure. And so no matter how you lower the blood pressure, whether it's an ACE or an ARB or calcium channel blocker, beta blocker, diuretic, you get a reduction in MI, stroke, and vascular death. Between individual drugs, there are differences, and we tend to use a lot of ACEs and ARBs, particularly in people with heart failure, with cardiac risk, and with renal disease. But it's all about the blood pressure. Now, the new guidelines that just came out at AHA last month suggest, like with lipids, we should be looking at risk and blood pressure. So the field keeps moving around. But I think when I sort of see patients and ask myself, am I doing a good job? The question is it 130 or over 80 or less? 130 or over 90, and that would be my kind of goal. It's more about the blood pressure.
Well, thank you very much for the lecture this morning. You're an icon in your field without overstating it. But you come from an organization that's got a huge legacy in treating vascular disease. So we're always interested in training the next generation of people who are going to replace us. And tell me a little bit about your journey and how you came to be in the position you're in at the moment.
Oh gosh, I feel like I'm a fortunate and blessed person. I really mean that. And I went to medical school at University of Colorado, where I'm born and raised. And Bob Rutherford was chief of vascular surgery, and he took me under his wing. And he became my first mentor. Bob Rutherford is a giant in vascular surgery. He wrote the textbook. He developed all the vascular lab standards we currently use now, and he unfortunately died a few years ago. But he became like a father figure to me. And during medical school, I did research in his vascular lab. I went away to Boston for my residency, came back, joined the faculty at the University of Colorado, and continued to work with Bob Rutherford. That went into the TASC guidelines, which was the first international guideline to treat peripheral artery disease. And Bob was just that really the mentor that you wanted to work for. He was excited about science. He was excited about his discipline. He made an impact, and he changed my life. The other person, when I was at Boston University, that John knows is Jay Kaufman, who's a vascular medicine doctor. At the time, there was just a handful of medical doctors that treated vascular disease. And Jay was my other key mentor, quite frankly. It's all about mentorship and motivation.
So let me ask you about vascular medicine, because it's probably not evolved as much as I thought it was going to a few years ago. And you guys have been heavily involved in the evolution of it. What do you think it's going to be in the next few years?
Well, we have to train the next generation. Now, there has been movement. So early in my career, there was very few training opportunities. Now, I'd say most major medical centers offer vascular training. At the University of Colorado, we have funding for a vascular fellow in both from the VA and from the university. We have a large cadre of vascular surgery and interventional radiology trainees, and we all pool together. So our didactics, our education is attributed to all the vascular disciplines. I think we have to invest in it. I think we have to see this as a common mission. So our practice is very much interdisciplinary, and I think surgeons and interventionalists working together with medical doctors who treat vascular disease is the wave of the future. The American Heart's invested in this quite a bit. As John is competing for a Strategic Network Award right now that I hope he gets. And so this is a long road coming, but it is coming. And I think we have to keep at it. But without trainees and new people to succeed us, there won't be much of a future. But I think there is.
That's great. Well, tell us a little bit more about the excitement with the Voyager study. Tell us about, you mentioned it briefly at our meeting today.
Yeah. Well, we this morning reviewed a number of different antithrombotic strategies to treat peripheral artery disease. The endpoints of interest are cardiac events, MI, stroke, vascular death, and we introduced a relatively new term, major adverse limb events, which you're very familiar with, which is acute limb ischemia, major amputation of a vascular cause, and a complex vascular surgical reconstruction. And these new therapies now are emerging as drugs that prevent not only cardiac events in people with PAD, but also limb events. And that's very exciting. And so we reviewed a bit some of the drugs. Ticagrelor plus aspirin seems to work in some patients, Vorapaxar and others. But more recently, the COMPASS trial showed that low doses of rivaroxaban, a selective factor Xa inhibitor, combined with aspirin, prevented cardiac and limb events in PAD. So my center is running an international trial called Voyager, which is looking at that same cocktail, low-dose rivaroxaban, 2.5 twice daily, plus aspirin, in patients who've just come out of the cath lab or the OR suite for a peripheral intervention. And so once they achieve hemostasis, they get randomized to rivaroxaban or placebo on a background of aspirin. And the endpoints are preventing heart attack, stroke, acute limb ischemia, and amputations. And we'll be finishing up that trial in about a year, probably report out early next 2019, which would be probably ACC or ESC for presenting the data. I'm very hopeful it's going to be a wildly positive trial and it'll change the way we treat people with vascular disease.
That's exciting. We'll look forward to that.
Yeah.
I have one more question, if I might. It's about your career. I mean, looking back, you've really climbed a mountain over this period of 30 years that we've known each other. It's amazing what you've accomplished. You're also a mountain climber. So tell us a little bit about that, about your mountain climbing.
Well, I grew up in Colorado, so there are a lot of mountains there. My father was a dentist, but he was a big mountain climber, and we started bagging peaks when I was early teens. There's 54 14ers, and then my dad and I got into a little competition. And so he actually beat me. He got up to 54th before I did because I was interviewing for my residency. I thought that was cheating. Subsequent to that, we started climbing in Wyoming and in the West, and then down in South America, and then over in Africa and Nepal and Tibet. And that's, to me, mountain climbing is very much a metaphor for what our academic life is about. You know, there's adversity, there's a summit, but there's also the journey up and the journey down. And it's just marvelous. And even today, I still, this summer, have done some climbing in the Rockies that's been challenging. At times I like to do it solo because I like the solitude. And it's just a great part of my life. But you got to live somewhere where it's not too flat like it is here in Houston. It's been great. I really love it still.
Thank you.
Yeah.
Well, you've climbed some major peaks.
Thank you.
Yeah.
And
Thanks
you
for
have
coming.
too, both of you.
Thanks for coming today. We really appreciate your presence.
Thank you, gentlemen.
Thank you.
Yeah.
All right. Good job.